Λοιπόν, θα ξεκινήσουμε το επόμενο τραπέζι, που είναι ένα φροντιστήριο, στην ουσία περισσότερο διαγνωστικό στις μεθόδους για την διάγνωση των δερματικών λεμφωμάτων. Είναι η χαρά μου και τιμή που είμαστε εδώ με τον κύριο Λεωνίδα Μαρίνο, ο οποίος είναι διευθυντής στο Παθολογικής Ανατομικής, στο αιματοπαθανατομικό εργαστήριο του Νοσοκομείου Ευαγγελισμός. Συνεργάζεται με τα μεγαλύτερα κέντρα στην Ελλάδα όσον αφορά τα δερματικά λεμφώματα. Και ο κύριος Μαρίνος θα μας πει για το πώς γίνεται η διάγνωση των δερματικών λεμφωμάτων.
Ευχαριστώ και εγώ για αυτή την πρόσκληση, την κυρία Παπαδαβίδη και την Οργανωτική Επιτροπή. Θα σας κουράσω λιγάκι, ως συνήθως, το ξέρετε αυτό και από άλλες μου παρουσιάσεις. Θα προσπαθήσω να τα τρέξω λιγάκι. Λοιπόν, το βασικό μας θέμα σήμερα είναι πώς γίνεται η διάγνωση των δερματικών λεμφωμάτων. Τεράστιο θέμα αυτό, έτσι, και ξεκινάει, έχει πολλές πτυχές, κλινικές και παθολογανατομικές. Από τη μεθοδολογία στη διάγνωση. Πώς μπορεί να ξεκινήσει κανείς, επιλέγοντας πρώτα το αντιπροσωπευτικό υλικό. Αυτό είναι η δουλειά την οποία θα κάνετε εσείς πρακτικά. Και όλα τα υπόλοιπα μετά τα αφήνετε σε εμάς. Οι μέθοδοι τις οποίες έχουμε στη διάθεσή μας είναι πολλές, αλλά ενδεχομένως να μην είναι αρκετές. Μορφολογία, ανοστοχημία, μοριακές τεχνικές, ανοσοθεσμός όχι, και θα δούμε για ποιο λόγο. Όλα λοιπόν ξεκινάνε επιλέγοντας το αντιπροσωπευτικό υλικό που θέλουμε να μελετήσουμε. Το αν θα πάρουμε χειρουργική βιοψία ή παντσάκι, αυτό σίγουρα παίζει ρόλο, στην αρχική μας προσέγγιση. Είναι πολύ βασικό και ίσως εδώ να κρύβεται και το κλειδί της διάγνωσης. Τι εννοούμε με αυτό? Χειρουργική βιοψία πότε? Όταν οι βλάβες δεν φαίνεται να είναι και τόσο αντιπροσωπευτικές. Όταν δηλαδή πρακτικά δεν δείχνουν πολύ έντονη διήθηση στο δέρμα. Έχουμε πλάκες χωρίς διήθηση, κοιλίδες ή πλάκες με ασαφείς χαρακτήρες. Όταν θέλουμε να επανεκτιμήσουμε αν υπάρχει πολυματική νόσος μετά από μια θεραπεία, που οι βλάβες μπορεί να είναι πολύ ήπιες. Στην ερυθροδερμία, που οι βλάβες μπορεί να κρύβονται σε ένα συγκεκριμένο σημείο, δεν ξέρουμε πού μπορεί να είναι αυτές. Πολλές φορές σε ερυθροδερμίες δεν δίνουμε απαντήσεις αυτές που περιμένει ο δερματολόγος από εμάς, γιατί πρακτικά δεν είναι διαγνωστικές. Άρα λοιπόν σε όλες αυτές τις περιπτώσεις, εδώ υπήρχε ένα animation εδώ, το οποίο δεν βγαίνει. Για ποιο λόγο? Αυτό. Από εδώ. Ναι. Λοιπόν. Όταν λοιπόν θέλουμε περισσότερο υλικό για μελέτη, θα επιλέξουμε σίγουρα τη χειρουργική βιοψία. Το παντσάκι είναι αρκετό για μικρές έκταση βλάβες, για διθυμένες πλάκες και για όγκους, γιατί εκεί πρακτικά όπου και να τσιμπήσουμε, είναι πολύ πιθανό να πέσουμε jackpot μέσα στην αλλίωση την οποία θέλουμε να μελετήσουμε. Άρα λοιπόν, προφανής και αναμενόμενοι στο παθολογία στις περιπτώσεις αυτές, με βάση την κλινική εικόνα, θα προτιμήσουμε το παντσάκι. Ερχόμαστε τώρα στη μορφολογία. Η μορφολογία είναι το α, βέβαια, και το ω της διαγνωστικής προσέγγισης των λεμφωμάτων. Γιατί το λέμε αυτό? Παίρνουμε πάρα πολλά στοιχεία για τα λεμφώματα. Αρχιτεκτονική διήθηση, κυταρική σύνθεση, μορφολογία κυτάρων, επιδερμοτροπισμός, λαγιοτροπισμός, σπογγίος, εξοκύτωση, διαταραχές της επιδερμίδας. Όλα αυτά είναι ένα puzzle το οποίο θα προσπαθήσουμε να το φτιάξουμε στην πορεία και από εκεί βασικά έχουμε ήδη βάλει το 70% της διάγνωσης. Ένα χαρακτηριστικό παράδειγμα για να καταλάβουμε πόσο μεγάλη σημασία της μορφολογίας. Στο αριστερό μέρος εδώ βλέπουμε πρακτικά μια βιοψία δέρματος η οποία φαίνεται ότι δεν έχει τίποτα πρακτικά. Όμως, αν κόψουμε βαθύτερες τομές, θα εμφανιστεί εδώ ένας εκτεταμένος επιδερμοτροπισμός. Πρακτικά αυτή είναι μια όρατη βλάβη που εάν μέναμε μόνο στην αρχική μας εκτίμηση, μπορεί να το προσπερνάγαμε και να λέγαμε μια παραψόριαση, μια δερματίτιδα. Αυτή είναι λοιπόν πολύ μεγάλη σημασία που δίνουμε πρώτον στις διαδοχικές τομές. Εδώ είναι μια άλλη περίπτωση πάλι, στην οποία και πάλι αριστερά δεν φαίνεται τίποτα εδώ. Όμως όταν κόψουμε βαθύτερα βγαίνει ένας τριχοθύλακας, ο οποίος φαίνεται βλαμμένος. Και γιατί είναι βλαμμένος? Γιατί έχει θύλακιοτροπισμό. Με το CD3 φαίνεται εκτεταμένη διήθηση. Μια βλάβη που ούτε και αυτή λοιπόν αρχικά φαίνονταν. Άρα λοιπόν πολύ βασικό η μορφολογία να προσέξουμε τι βλέπουμε πάντοτε στην αρχή και να είμαστε πάντα επιφυλακτικοί σε αυτό που βλέπουμε. Η κυταρική σύνθεση μας δίνει πάρα πολλά στοιχεία η μορφολογία. Τα χαρακτηριστικά κύτταρα της νόσου, Σέζαρη εδώ. Το αν έχουμε ένα οζώδες ή διάχυτο πρότυπο ανάπτυξης μας βοηθάει πάρα πολύ να κατευθυνθούμε σε αντίστοιχα πρότυπα β' λεμφωμάτων. Να ξεχωρίσουμε ένα λέμφωμα από μια άλλη νεοπλασματική εξεργασία. Να ξεχωρίσουμε μεταξύ διαφόρων λεμφωμάτων, β' ταφ, NK λεμφώματα, μόνο με την ανοστοχημία. Επιμέρους διάκριση υποκατηγοριών, β' ή τ' λεμφωμάτων, διαιρέσεις προγνωστικών δικτών, όπως είναι το K67 και το ALK1, ανίχνευση ιών, Epstein-Barr, HHV8, όλα αυτά μπορούμε να τα δούμε μόνο με την αναστοχημία. Βέβαια, στην αναστοχημία να είμαστε πάντα προσεκτικοί, διότι χρειάζεται πάντα ένας ποιοτικός έλεγχος, γιατί μπορεί να έχουμε ψευδώς θετικές, ψευδώς αρνητικές και το αντίστροφο πάντοτε, και σε όλες αυτές τις περιπτώσεις θα οδηγηθούμε σε λάθος διάγνωση. Εδώ ένα χαρακτηριστικό παράδειγμα πάλι. Μπορούμε να ξεχωρίσουμε το λέμφωμα από μια ελληνοπλασματική εξεργασία. Έτσι. Με το CD45 αριστερά βλέπουμε πρακτικά ένα λέμφωμα και εδώ με το HMB45 βλέπουμε ένα μελάνομα. Μορφολογικά, αν τα βλέπαμε και τα δύο, θα υπήρχε δυσκολία ενδεχομένως να τα ξεχωρίσουμε. Β versus TAF versus NK. Εδώ βλέπουμε ένα λέμφωμα οριακής ζώνης, πλασματοκυταρική διαφοροποίηση. Πρακτικά είναι μια χρώση αυτή που μας βάζει τη διάγνωση. Δεν χρειαζόμαστε τίποτε άλλο. Ξολεμφαδενικό NK λέμφωμα αρνητικού τύπου, CD56 θετικό, πρακτικά διαγνωστικό για αυτό το λέμφωμα, όχι μόνο, αλλά σε συνδυασμό και με άλλα. Έτσι. Συγκεκριμένοι αλγόριθμοι ανοσοφενοτυπικής έκφρασης για το πρωτοπαθές δερματικό λέμφωμα βλαστικού κέντρου, συνδυασμός δηλαδή CD10 έκφρασης, χαμηλού και 67 στο βλαστικό κέντρο, αρνητικότητα στο BCL2, χαρακτηριστικό για το πρωτοπαθές δερματικό λέμφωμα, και θετικότητα στο BCL6, είναι, πώς λέμε, visually diagnostic. Πρωτοπαθές δερματικό λέμφωμα οριακής ζώνης. Το hallmark στις περισσότερες περιπτώσεις είναι η ταυτοποίηση κλονικότητας σε επίπεδο πλασματοκυτάρων, όπως βλέπουμε εδώ, έτσι, CAG-K. Δεν υπάρχει πάντα. Τώρα όλο ένα και περισσότερο βάζουμε διαγνώσεις που δεν έχουν κλονικότητα σε πλασματοκυταρική έτσι συνιστόσα. Σποκουδίσμικη διάση versus αναπλαστικό λέμφωμα από μεγάλα λεμφοκύτταρα, και εδώ βλέπουμε μεγάλα κύτταρα τα οποία με το CD30 μπορεί να είναι θετικά και CD3 θετικά. Η αναστοχημία θα μας βοηθήσει να ταυτοποιήσουμε την έκφραση του CD30, πολύ βασική και για τις δύο κατηγορίες λεμφωμάτων. Η έκφραση του K67 επίσης, προγνωστικός δείκτης σημαντικός. Και πάντα όμως πρέπει να διατηρούμε μια επιφυλακτική στάση όσον αφορά την αναστοχημία. Γιατί? Διότι υπάρχει σίγουρα αλληλοπεκαλυπτόμενη εικόνα με β' ψευδολεμφώματα πολλές φορές και η αναστοχημία δεν θα μας βοηθήσει. Η απουσία έκφραση του BCL2 σε λεμφώματα βλαστικού κέντρου. Έτσι, δεν μπορούμε να τεκμηριώσουμε την κλονική φύση. Το πράγμα το οποίο μπορούμε να κάνουμε πολύ εύκολα στο λεμφαδένα, που είναι BCL2 θετικά τα λεμφώματα. Άρα λοιπόν, αυτοί είναι περιορισμοί που πρέπει να τους έχουμε υπόψη μας στην προσέγγιση μας πάντοτε. Στα TAF λεμφώματα. Και εκεί υπάρχει μεγάλη δυσκολία, ίσως μεγαλύτερη από τα β' λεμφώματα, διότι έχουμε αλληλοκαλυπτόμενο νοσοφενότυπο με άλλα TAF δερματικά λεμφώματα, αντιδραστικούς λεμφοκυταρικούς πληθυσμούς, πολλές φορές είναι περισσότεροι από την νεοπλασματική εξεργασία. Και έτσι λοιπόν υπάρχει αδυναμία ταυτοποίησης κλονικότητας, και αυτό μπορεί να γίνει μόνο με έμεση ταυτοποίηση της νεοπλασματικής φύσης μέσω ανώμαλης ανοσοποιητικής έκφρασης, όταν αυτή υπάρχει, που δεν υπάρχει πάντοτε. Οι μοριακές κυταρογενετικές τεχνικές, μία πλειάδα από αυτές. Πότε τις χρησιμοποιούμε? Όταν υπάρχει αδυναμία τεκμηρίωσης με την αναστοχημία, όταν θέλουμε να δούμε ελαχίστη νόσο και να εκτιμήσουμε τη θεραπευτική ανταπόκριση, να κάνουμε μια έγκαιρη διάγνωση μιας υποτροπής που δεν φαίνεται ενδεχομένως σε μορφολογικό επίπεδο, ας πούμε, ούτε και σε κλινικό ενδεχομένως μερικές φορές, να ανιχνεύσουμε μεταθέσεις με ειδική διαγνωστική προγνωστική αξία, και βέβαια όλα αυτά πολλές φορές βοηθούν στη συμβολή και προσφέρουμε δηλαδή πράγματα για τις καινούργιες ταξινομίες που βγαίνουν, ας πούμε, συνεχώς. Ποια είναι τα πλεονεκτήματα των μοριακών τεχνικών? Δεν εξαρτώνται από την αντιγονική έκφραση, γιατί πηγαίνουν κατευθείαν στο DNA του πυρήνα. Πληροφορίες σχετικά με την παθογένεση, διάγνωση και πρόγνωση αιματολογικών νόσων επίσης μπορούν να μας τις δώσουν, σε απλόχερα βέβαια. Τα πλεονεκτήματά τους ποιο είναι? Είναι το κόστος, είναι πολύ ακριβές, θέλουν ειδικό εξοπλισμό, έμπειρο προσωπικό που να μπορεί να διαβάσει τα αποτελέσματα και εξειδικευμένο εργαστήριο που μπορεί να κάνει τις τεχνικές. Και βέβαια, αυτό που είναι πολύ σημαντικό, προσοχή στην ερμηνεία των αποτελεσμάτων. Γιατί πολλές φορές το θετικό δεν σημαίνει νόσο και το αρνητικό επίσης δεν σημαίνει ότι είναι αντιδραστικό. Η PCR ανάλυση. Βασική αρχή εδώ ότι μια αντιδραστική εξεργασία πολυκλονικού χαρακτήρα στηρίζεται στο ότι κάθε κλόνος έχει διαφορετική αναδιάταξη. Οπότε, όταν θα πάμε στην ανοσολεκτροφόρηση στο πίκτωμα αγαρόζης, πρακτικά εδώ δεν θα υπάρχει έντονη εικόνα, γιατί θα υπάρχει μια σαφοποίηση, γιατί όλα τα κύτταρα θα πάνε σε διαφορετικές, ας πούμε, έτσι, σε διαφορετικά ύψη. Ενώ στην πλασματική εξεργασία που είναι ένας και μόνο κλόνος, όλα μαζί θα συνοστιστούν σε ένα συγκεκριμένο σημείο και θα πάρουμε την έντονη αυτή αναδιάταξη. Βέβαια, να πω τώρα ότι η PCR είναι ξεπερασμένη. Απλά εμείς τη χρησιμοποιούμε στο εργαστήριο, γιατί εντάξει, την ξέρουμε πάρα πολλά χρόνια και δεν έχουμε τη δυνατότητα την οικονομική να πάμε και σε άλλες τεχνικές που είναι πιο κοστοβόρες, και όπως ξέρετε, είμαστε όλοι οικονομοεξαρτώμενοι από άλλες αρχές. Οι εφαρμογές της PCR σε λιπλαστικές εξεργασίες, ανίχνευση κλονικότητας σε β' ή τ' κυταρικής προέλευσης εξεργασίες, διαφορική διάγνωση μεταξύ μονοκλονικής και πολυκλονικής λεμφοπλασίας, ανίχνευση ελαχίστης πολυματικής νόσου, χρονοσωμικές μεταθέσεις κλπ. Τα πλεονεκτήματά της είναι ότι μεγάλη ευαισθησία της μεθόδου, ότι είναι αυτοματοποιημένη και μπορεί να χρησιμοποιηθεί και υλικό από το αρχείο. Περιορισμοί και διαγνωστικές παγίδες. Η ευαισθησία της μεθόδου έτσι, δεν είναι πάντα 100%. Η κλονικότητα δεν ισοδυναμεί πάντα με κακοήθεια, το λέμε πάντοτε αυτό. Ψευδοκλονικότητες, ολιγοκλονικότητες, ψευδοαισθητικά αποτελέσματα, ψευδοαρνητικά, όλα αυτά μας κάνουν να είμαστε πάντοτε πολύ επιφυλακτικοί και να αξιολογούμε όλες μας τις παραμέτρους πριν δώσουμε την τελική διάγνωση. Στα β' λεμφώματα, η PCR βοηθάει να ανιχνεύσουμε κλονικές αναδιατάξεις στα γονίδια των βαριών ή των ελαφρών αλύσεων των ασφαιρινών. Στα ταφ λεμφώματα μπορεί να χρησιμοποιηθεί για τη διάγνωση, για την επιβεβαίωση της νόσου, για το follow-up, για τη διάγνωση των πρώιμων σταδίων της υποκοειδούς μυκητίασης, όταν δεν έχουμε επιδερμοτροπισμούς και τέτοια πράγματα, και βέβαια τη σταδιοποίηση του συνδρόμου Σέζαρη. Ο φθορής in situ υβριδισμός. Πότε είναι δεδειγμένη τεχνική? Όταν και η αιμοριακή ανάλυση με PCR έχει αποτύχει για συγκεκριμένες αναδιατάξεις, όταν και η κυταρογενετική διαταραχή την ξέρουμε μεν, αλλά δεν έχουμε ταυτοποιήσει το γονίδιο. Σε in situ λεμφώματα, στο οποίο υπάρχουν αμφίβολα αναστοχημικά αποτελέσματα, όπως είναι το in situ λεμφοζydιακό λέμφωμα και το in situ λέμφωμα από κύτταρο-μανδύα, αυτό βέβαια δεν αφορά το δέρμα κυρίως, αφορά τους λεμφαδένες. Και για χρωμοσωμικές μεταθέσεις και πολύπλοκες αναδιατάξεις, λόγω του ότι απαιτείται μεγάλος αριθμός εκκινητών για να γίνει PCR εκεί. Στην υποκοειδή μυκητίαση τα αποτελέσματα είναι περιορισμένα και δεν είναι και καθοριστικά. Έχουν περιγραφεί δηλαδή translocations 17-8, αναδιατάξεις 1p17q και διαταραχές του χρωμοσώματος 10. Αλλά αυτά όμως σε καμιά περίπτωση δεν είναι ικανά από μόνα τους να είναι καθοριστικά, ώστε να μπει κανείς ούτε καν οφής για να βάλω και διάγνωση στην υποκοειδή μυκητίαση. Στο αναπλαστικό λέμφωμα από μεγάλα λεμφοκύτταρα είναι πιο καλά τα πράγματα, γιατί εκεί μπορούμε να ξεχωρίσουμε τα άλκα αρνητικά από τα αλθετικά. Οι αναδιατάξεις στο γονιδιακό επίτοπο DUSP 22 έχουν, ας πούμε, μισό λεπτάκι, ναι, εδώ, versus TP63 αναδιατάξεις. Οι πρώτες έχουν πολύ καλύτερη βιολογική πρόγνωση. Το νεόπλασμα πηγαίνει πολύ καλύτερα όταν υπάρχει το RF4 αναδιάταξη, ενώ στο TP63 είναι δυσμενής προγνωστικός δείκτης. Οι ανομαλίες του γονιδίου MALT στο λέμφωμα της οριακής ζώνης και η τρισομία 18 που ανιχνεύεται σε ποσοστό 25% με το FIS. Η απουσία της BCL2 αναδιάταξης και μετά τις translocation 14-18 σε λίγες περιπτώσεις για το λέμφωμα του βλαστικού κέντρου. Αυτά μπορεί να μας βοηθήσει, ας πούμε, το FIS. Και βέβαια έχει μια πολύ μεγαλύτερη ευαισθησία όσον αφορά την PCR στην ανίχνευση του translocation 14-18 στο λέμφωμα βλαστικού κέντρου. Δεν είναι 100%, είναι γύρω στο 41%, αλλά και αυτό μερικές φορές μπορεί να είναι αρκετό να μας βοηθήσει όταν έχουμε τα υπόλοιπα. Ακόμη υπάρχουν σημειακές μεταλλάξεις των γονιδίων BCL6, MIC, RO, TTF και PAX5, γύρω στο 50% των περιπτώσεων. Στο λέμφωμα από μεγάλα β' λεμφοκύτταρα του κάτω άκρου, το πρωτοπαθές δερματικό, μπορεί να μας δώσει διάφορες πληροφορίες εδώ. Βλέπουμε αντίστοιχα όλα αυτά τα πράγματα εδώ, απενεργοποιήσεις γονιδίων, εκφράσεις μεταγραφικών παραγόντων, έκφραση MAM, τα οποία όλα είναι ενδεικτικά, ας πούμε, προγνωστικοί δείκτες βασικά. Έτσι, αυτή είναι η δυσμενής πάνω που είδαμε. Ενώ η αυξημένη έφραση του FOXP3 στα νοπλασματικά κύτταρα και στα δημιστικά ταφ λεμφοκύτταρα θεωρείται προγνωστικός δείκτης, εδώ ευνοϊκός. Μια πολύ μεγάλη έτσι, εδώ, ομάδα από μοριακούς δείκτες που μπορεί να έχουν ενδεχόμενη μελλοντική προγνωστική αξία. Δεν θα μπούμε τώρα σε λεπτομέρειες, είναι πάρα πολλά αυτά, δεν θα τα προλάβουμε όλα. Η κυταρομετρία ροής, μια μέθοδος μέτρησης πολλαπλών φυσικών και χημικών χαρακτηριστικών, όπως ξέρουμε, σωματιδίων με οπτικά μέσα, δεν έχει πολύ μεγάλη εφαρμογή. Έτσι, στα λεμφώματα που μπορούμε να τη χρησιμοποιήσουμε, να δούμε νεοπλασματικά β' λεμφοκύτταρα στο περιφερικό αίμα και αυτό πότε γίνεται, όταν έχουμε μια δευτεροπαθή συμμετοχή του δέρματος σε χρόνια λεμφοκυτταρική λευχαιμία ή σε λέμφωμα από το κύτταρα του μανδύα. Μια περίπτωση εδώ, CLL που διηθεί με το δέρμα. Και εδώ με το CD5. Έτσι. Και όσον αφορά τα ταφ λεμφώματα, βέβαια, τη χρησιμοποιούμε για να ανιχνεύσουμε τα κύτταρα Σέζαρη στο περιφερικό αίμα, όπως ξέρουμε, που υπάρχει συγκεκριμένο ανοσοφιλοτυπικό προφίλ των κυττάρων αυτών, όπως βλέπουμε και εδώ. Πού ακόμα μπορούμε να τη δούμε? Όταν υπάρχει συμμετοχή του δέρματος στην τάφρο λεμφοκυτταρική λευχαιμία, στην τάφη λευχαιμία λέμφωμα των ενηλίκων, adult T-cell leukemia λυμφώμα, και στη λευχαιμία από τάφη NK ή αμυγός NK κτλ. Δηλαδή σε όλες τις λευχαιμικές καταστάσεις θα μας βοηθήσει η κυταρομετρία ροής για να έχουμε μια ολοκληρωμένη εικόνα της νόσου, έχοντας την εικόνα από το δέρμα, να έχουμε και την εικόνα από το περιφερικό αίμα. Ο ανοσοφθορισμός δεν αποτελεί μέθοδο απαραίτητη για τη διάγνωση των δερματικών λεμφωμάτων και χρησιμοποιείται πολύ σπάνια και επιλεκτικά μόνο στη διαφορετική διάγνωση από πομφολιγώδη εξανθήματα που ιστολογικά θέτουν υπονέες λεμφόμετος. Εδώ είναι μια τέτοια περίπτωση. Μια υποκοδής μυκητίας πομφολιγώδης, ένα πομφολιγώδες πεμφυγοειδές και μια πέμφυγα. Εδώ μορφολογικά είναι δύσκολα τα πράγματα για μας, έτσι, γιατί πρακτικά λεμφοκύτταρα υπάρχουν και εδώ υπάρχουν και ιωσνόφυλλα, έτσι. Εδώ μπορεί να υπάρχουν και λεμφοκύτταρα και εοζινόφυλλα. Έχουν βέβαια τα χαρακτηριστικά του pattern, τα οποία είναι διαφορετικά, αλλά εν πάση περιπτώσει σίγουρα δημιουργείται ένας προβληματισμός εδώ αρχικά. Εδώ θα μας έλυνε το πρόβλημα βέβαια ο νοσοφθορισμός, έτσι, διότι έχουν άλλα pattern εδώ πέρα. Βλέπουμε ένα IgG linear basement membrane zone και C3 linear basement membrane zone στον νοσοφθορισμό όσον αφορά το πέμφυγοειδές. Η πέμφυγα επίσης έχει αυτή την καλαθοειδή, έτσι, ανάδειξη του φθοριοχρώματος εδώ. Και κλείνοντας εδώ το κομμάτι των διαγνωστικών μεθόδων για τα δερματικά λεμφώματα, να πούμε ότι όλα είναι ένα puzzle στην ουσία. Δηλαδή, μορφολογία, ανοστοχημία, PCR και FIS συμπληρώνουν το ένα το άλλο και μας βοηθούν τελικά να φτάσουμε στη διάγνωση. Τώρα, να πούμε λίγα πράγματα πώς γίνεται η διάγνωση στα συνηθέστερα πρωτοπαθή δερματικά λεμφώματα. Βλαστικό κέντρο versus οριακή ζώνη. Κλινικές εικόνες. Ποιο είναι ποιο. Κανείς δεν μπορεί να το πει εδώ με σιγουριά. Επομένως, κλινικά ενδεχομένως δεν θα μπορούσαμε εδώ σε καμιά περίπτωση να βάλουμε διάγνωση. Η μορφολογία βοηθάει. Θα έλεγα ότι είναι υπενικτική, αλλά μη διαγνωστική πολλές φορές. Εδώ βλέπετε ένα λέμφωμα λεμφοζυδιακό και ένα λέμφωμα οριακής ζώνης. Αν μπορούμε να εντοπίσουμε τις διαφορές, θεωρώ ότι δεν θα είναι και πάρα πολύ εύκολο. Το ζώδες πρότυπο ανάπτυξη που λένε μετά για το ζώδες λέμφωμα δεν ισχύει πάντοτε, διότι υπάρχει και η διάχυτη μορφή του. Όπως και το λέμφωμα οριακής ζώνης μπορεί να απικίζει λεμφοζύδια και να φαίνεται ο ζώδες ενώ είναι λέμφωμα οριακής ζώνης. Η ανοστοχημία συχνά διαγνωστική τις περισσότερες φορές, ειδικά στο λέμφωμα από την οριακή ζώνη, όπου υπάρχει πλασματοκυταρική διαφοροποίηση εδώ. Έτσι. Και βέβαια στο λέμφωμα βλαστικού κέντρου που είναι BCL6 θετικό και BCL2 αρνητικό. Βέβαια, πρέπει να έχουμε πάντοτε υπόψη μας ότι η διαφορετική διαγνωστική πάντοτε γίνεται και από μια αντιδραστική λεμφοκυταρική εξεργασία, το παλαιότερο καλούμενο β' ψευδολέμφωμα. Και πώς γίνεται αυτό τώρα. Συχνά υπάρχει ζώνη ελεύθερη διήθηση μεταξύ της λεμφοκυταρικής διήθησης και της επιδερμίδας, αυτή που λέμε grand zone. Υπάρχουν λεμφοζυδιακοί σχηματισμοί αρκετά συχνά, ήδη έχει το πρότυπο ανάπτυξης και επιδερμοτροπισμό μπορεί να υπάρχει και να μην υπάρχει. Άρα λοιπόν σε όλες αυτές τις περιπτώσεις και το ψευδολέμφωμα και το λέμφωμα μπορεί να έχουν τα ίδια χαρακτηριστικά. Τώρα, πώς γίνεται η διαφορετική διάγνωση του πρωτοπαθούς δερματικού λεμφώματος βλαστικού κέντρου από ένα ψευδολέμφωμα. Η παρουσία του BCL6 και CD10 θετικών κοιτάνω στο μεσολεμφοζυδιακό χώρο είναι πρακτικά λέμφωμα. Το χαμηλό και 67 στα βλαστικά κέντρα είναι λέμφωμα και δεν είναι ψευδολέμφωμα. Και βέβαια, αν αποδείξουμε και κλονικότητα με την PCR ανάλυση, ακόμη καλύτερα. Τώρα, για την οριακή ζώνη, το δερματικό λέμφωμα βλαστικού κέντρου και το ψευδολέμφωμα σίγουρα μας δημιουργούν προβληματισμό εδώ. Και θα πρέπει, όπως είπα, να χρησιμοποιήσουμε όλες μας έτσι τις δυνατότητες. Και την ανοστοχημία και τη μοριακή ανάλυση. Τώρα, για τα συνηθέστερα περνάμε στην κατηγορία των ταφ δερματικών λεμφωμάτων. Τα ίδια πράγματα και εδώ. Μορφολογία, ανοστοχημία, μοριακές τεχνικές. Σπονγκοειδής μυκητίαση έχει μεγάλη ετερογένεια σε κλινικό και στο λογικό επίπεδο, όπως ξέρουμε όλοι, έτσι. Κοιλίδες, πλάκες, όγκη, ερυθροδερμία. Και έτσι είναι δύσκολη η διάγνωση τόσο κλινικά όσο και ιστολογικά, όπως έχουμε δει όλοι μας στην καθημερινή πράξη. Κλινικές εικόνες εδώ, πάρα πολλές μορφές. Όταν έχουμε αυτό, μπορούμε να βάλουμε τη διάγνωση. Είναι ένα αποστημάτιο ποτριέ, λεμφοκύτταρα μέσα στην επιδερμίδα, νεοπλασματικά, άτυποι πυρήνες, υπερχρωματικοί. Έτσι λοιπόν, κάποιες φορές μπορεί να είναι διαγνωστική η μορφολογία. Συνήθως όμως δεν είναι έτσι τα πράγματα. Άλλες φορές έχουμε αυτό. Αυτό είναι ένα πατς και αυτό είναι μια πλάκα. Εδώ αν δεν έχουμε κάποια στοιχεία που να μπορούμε να το ξεχωρίσουμε αυτό από κάτι άλλο. Άρα λοιπόν εδώ δεν μπορούμε με τη μορφολογία να βάλουμε διάγνωση. Τότε έρχεται η ανοστοχημία. Ένα ευρύ φάσμα δικτών, που το ρίχνουμε και αυτό εκεί στην φαρέτρα μας. Αν έχουμε ανώμαλο οσοφενότυπο όπως σε αυτή την περίπτωση, εδώ βλέπουμε δηλαδή ότι τα ταφ λεμφοκύτταρα έχουν χάσει την έκφραση του CD5 και πάρα πολύ λίγα είναι CD3. Αυτές οι περιπτώσεις μπορούμε εδώ με ασφάλεια να το βάλουμε. Πρακτικά το έχω δει πάρα πολύ λίγες φορές. Ο επιδερμοτροπισμός είναι από τα πιο βασικά μας στοιχεία, έτσι. Όταν τον έχουμε, πολλές φορές βάζουμε τη διάγνωση. Η εκτροπή της, μεγάλη προσοχή εδώ, έτσι. Θα το καταλάβουμε πολύ εύκολα βέβαια, διότι θα έχουμε ένα γνωστό ιστορικό σπονγκοειδούς μυκητίασης, κάτι δεν θα έχει πάει καλά. Θα μας πείτε εσείς ότι υπάρχει ένας όγκος εκεί μεγάλος. Έτσι. Θα δούμε εμείς αυτή την εικόνα εδώ με μεγάλα λεμφοκύτταρα. Πρακτικά έχουμε βάλει τη διάγνωση της εκτροπής. Η CD30 έκφραση, όπως ξέρουμε, μπορεί να είναι θετική, μπορεί να είναι και αρνητική σε περιπτώσεις εκτροπής. Άρα λοιπόν εκτροπή δεν σημαίνει πάντα και CD30 θετικότητα. Και βέβαια η διαφορετική διάγνωσή μας εδώ περιλαμβάνει πάρα πολλά πράγματα, όπως είναι το πρωτοπαθές αναπλαστικό λέμφωμα από μεγάλα λεμφοκύτταρα, λεμφωματοειδής βλατίδωση, το συστηματικό αναπλαστικό λέμφωμα με δευτεροπαθή εντόπιση στο δέρμα, η εκτροπή της σπονγκοειδούς βέβαια και η καλοήθηση μηνοπλασματική CD30 θετικές εξεργασίες. Πάρα πολλές φορές έχουμε δει CD30 θετικά κύτταρα Έτσι, τα οποία όμως από μόνα τους δεν βάζουν τη διάγνωση της νεοπλασίας. Εδώ είναι πρωτοπαθείς διαδευτικές λεμφοπλαστικές εξεργασίες, με την αλληλοεπικάλυψη την οποία έχει η λεμφωματοειδής βλατίδωση με το αναπλαστικό λέμφωμα. Το χαρακτηριστικό και των δύο είναι τα CD30 θετικά λεμφοκύτταρα. Η λεμφωματοειδής βλατίδωση δεν χρειάζεται να τα πούμε, έτσι τα γνωρίζετε πολύ καλύτερα από μένα αυτά. Έτσι, εδώ είναι μια περίπτωση εδώ, λεμφωματοειδής βλατίδωσης τύπου Α, πολύ CD30, έχει όμως και άλλα κύτταρα ανάμεσα. Το δερματικό αναπλαστικό λέμφωμα επίσης και αυτό μονόμορφος πληθυσμός από μεγάλα λεμφοκύτταρα, η ανοστοχημία του CD30 θετικά. Αν μπορούμε να κάνουμε ένα μικρό διαχωρισμό μεταξύ λεμφωματοειδούς βλατίδωσης και αναπλαστικού λεμφώματος, το μέγεθος των βλαβών, συνήθως η λεμφωματοειδής βλατίδωσης είναι κάτω από 2 εκατοστά και ο αριθμός, συνήθως είναι πολλαπλές οι βλάβες της λεμφωματικής βλατίδωσης σε σχέση με τον αναπλαστικό λέμφωμα μεγάλα λεμφοκύτταρα, αλλά αυτό όμως δεν συμβαίνει πάντοτε, γιατί σε ένα ποσοστό 20% το αναπλαστικό λέμφωμα μπορεί να έχει και πολλαπλές εντοπίσεις, οπότε τότε μπλέκονται λίγα και τα πράγματα. Ένα χαρακτηριστικό παράδειγμα εδώ, η κλινική εικόνα, δεξιά λεμφωματοειδής, αριστερά primary cutaneous anaplastic. Αυτό λοιπόν βοηθάει η κλινική εικόνα, αλλά με επιφυλάξεις πάντοτε. Να έχουμε πάντα στο μυαλό μας ότι μπορεί να έχουμε αναπλαστικό μεν λέμφωμα και μορφολογικά και κλινικά και ανοστοχημικά, αλλά αυτό όμως να είναι συστηματική εκδήλωση ενός άλλου λεμφώματος που υπάρχει σε ένα λεμφαδένα, έτσι, και να υπάρχει δευτεροπαθή συμμετοχή στο δέρμα. Συνήθως το translocation 2.5, η έκφραση του EMA, η έκφραση του ALK και οι ανατομικές εντοπίσεις εκτός από το δέρμα μας βάζουν τη διάγνωση ότι αυτό είναι ένα συστηματικό λέμφωμα δευτεροπαθές στο δέρμα και δεν είναι ένα πρωτοπαθές του δέρματος. Η εκτροπή της υπογκοντρούς μυκητίασης κάνει διαφορετική διάγνωση από τα υπόλοιπα, διότι έχουμε το προηγούμενο ιστορικό και έχουμε και προχωρημένο στάδιο συνήθως. Το βλέπουμε συνήθως στο στάδιο όγκου. Σπανίως έχουμε δει και περιστατικά σε πλάκα, αλλά είναι exceptional cases αυτά. Στη διαφορική διάγνωση τώρα υπάρχουν καλώδεις μυροπλασματικές διαδευτικές εξεργασίες. Εκεί μόνο το ιστορικό και η κλινική εικόνα μπορεί να μας βοηθήσει. Γιατί η μορφολογία ανοστοχημία θα είναι ίδιες με αυτές των CD30 θετικών εξεργασιών νεοπλασματικών που είδαμε προηγουμένως. Τώρα, η πρωτοπαθής δερματική CD4 λεμφοπλαστική διαταραχή από μικρά μέσου μεγέθους λεμφοκύτταρα, έτσι, μοιάζει πάρα πολύ με ψευδολέμφωμα. Το μόνο στοιχείο το οποίο μπορεί να την ξεχωρίσει είναι η μοριακή ανάλυση, που είναι απαραίτητη για τη διάγνωση, έτσι, διότι εκεί θα δούμε κλονικότητα σε αντίθεση με τα ψευδολεμφώματα. Εδώ είναι μια τέτοια περίπτωση από αυτή την εξεργασία, την κλινική. Το εξολεμφαδενικό είναι και λεμφομαρινικού τύπου, έχει χαρακτηριστική έκφραση του CD56 και του Grand Giant B. Έτσι, έχει εκτεταμένες βλάβες κτλ. Μοιάζει με το primary cutaneous epidermotropic CD8 cytotoxic λυμφώμα. Το NK ταφ λεμφομαρινικού τύπου, επομένως, δύο πράγματα, ABV και CD56, διάγνωση. Το πρωτοπαθές δερματικό γαμαδέλτα ταφ λέμφωμα. Κλινική εικόνα, εξλικωμένα δερματικά ογκίδια, μεταστάσεις σε άλλες εξολεμφαδενικές θέσεις, β' συμπτωματολογία και αιμοφαγοκυταρικό σύνδρομο. Η διαφορική του διάγνωση από το υποδόριο ταφ λέμφωμα μιμούμενο υποδερματίτιδα, το οποίο είναι TCR γαμαδέλτα αρνητικό σε αντίθεση με το πρωτοπαθές γαμαδέλτα, CD8 θετικό και CD56 αρνητικό σε αντίθεση και αυτό με το γαμαδέλτα. Το εξολεμφαδενικό θα είναι EBV θετικό. Και είναι το βάθη ρυθματώδης λύκους, που είχαμε πρόσφατα ένα παράδειγμα τέτοιο που είχε προβληματίσει πάρα πολύ, εμένα συγκεκριμένα αυτό. Έτσι. Λοιπόν, το οποίο έμοιαζε να είναι ρυθματώδης λύκους, είχε ελάχιστα CD56 κύτταρα. Θεώρησα ότι ήταν το βάθη υποδερματίτιδα λύκου. Στην πορεία όμως, σε μια καινούργια βιοψία, ήταν full 56 θετικό, TCR γ-δ θετικό και αποδείχθηκε τελικά ότι ήταν ένα λέμφωμα γ-δ, το οποίο ήταν masked under της εικόνας, ας πούμε, του ρυθματώδης λύκου. Άρα λοιπόν, δύσκολη διάγνωση και αυτή, θέλει μεγάλη προσοχή, γιατί έχει πολύ μεγάλη σημασία για τον άρρωστο. Κακή πρόγνωση, όπως ξέρουμε, αλλά, όπως ξέρει και η κυρία Παπαδίδη εδώ, είχαμε και περιπτώσεις που είχαν ήπια βιολογική συμπεριφορά. Μια ασθενής η οποία ήταν περίπου 10 χρόνια. Η μορφολογία λοιπόν δεν βοηθάει και εδώ, καθόλου σχεδόν θα πω. Η ανοστοχημία είναι πιο χαρακτηριστική, γιατί έχουμε θετικότητα στο CD56 εδώ και βέβαια το TCR-γ, το οποίο είναι θετικό. Εδώ λοιπόν βλέπουμε TCR-γ θετικότητα στη διήθηση που είδαμε προηγουμένως, virtual diagnostic εδώ, ενώ το VF1 για τα ΑΒ κύτταρα είναι αρνητικό. Επομένως, η διάγνωση των δερματικών λεμφωμάτων να πούμε ότι είναι συνισταμένη κλινικών, μορφολογικών, ανοστοχημικών και μοριακών δεδομένων και απαιτεί οπωσδήποτε τη συνεργασία και των τριών εμπλεκομένων μερών: δερματολόγου, παθολογατόμου και βιολόγου που θα κάνει τις μοριακές τεχνικές. Ευχαριστώ πάρα πολύ.
Ευχαριστούμε πολύ τον κύριο Μαρίνο. Να κάνουμε τις ερωτήσεις στο τέλος. Νομίζω να μιλήσει και ο ο καθηγητής ο Πρατιστέλα που είναι συνδεδεμένος μαζί μας και η κυρία Χόπκινς και στο τέλος να κάνουμε μια καλύτερη συζήτηση, εκτός αν υπάρχουν ερωτήσεις τώρα για τον κύριο Μαρίνο. Οπότε προχωράμε στον επόμενο ομιλητή και θα τα πω τώρα στα αγγλικά γιατί είναι συνδεδεμένος. Είμαστε εντάξει? Εντάξει. Okay. It's a great pleasure to introduce a great collaborator and very well-known professor of pathology specialized in dermatopathology, Maxime Pratistella, who is actually a board member of the EORTC, and he is a leading pathologist at the Proclipi study. And Maxime, it's a great pleasure to have you with us. Unfortunately, the previous lecture was in Greek. It was a great overview on most of the types of cutaneous lymphomas. And we are very happy to have your lecture on what's new in dermatopathology.
Good morning, everybody. I hope you can hear me well. Thank you, Evangelia, for your kind invitation. I'm sorry not being able to be here in Greece. I'm in Paris. And do you see well my screen?
Yes, yes. Can you? Is it possible to have it full screen? It's or that's
For
okay.
me, it's full
That's
screen.
okay. Yeah, that's fine. That's fine. Yeah, yeah.
Okay.
It's okay. Yeah, yeah.
So, as Professor Papadavid told you, I'm previously trained as a dermatologist and a pathologist now, and I'm performing dermatopathology and also hematopathology, especially in the field of cutaneous T-cell lymphoma. And I will talk to you this morning about lymph node pathology in mycosis fungoides and Sézary syndrome, its importance, how can we sample the lymph nodes, how do we stage the lymph nodes, and the importance for the prognosis and taking care of these patients. As you may know, mycosis fungoides and Sézary syndrome are staged. You can see here the international staging system, which is based on the extent of skin diseases, the T stage, nodal disease. I will talk about that this morning. The metastatic diseases, which is quite rare in mycosis fungoides, and the blood involvement. You can see that, of course, you may know that there are the patches, the plaques, the tumors, and the erythroderma, defining according to the extent the different T stage. And most what we call early mycosis fungoides are people that have only cutaneous involvement with stage T1 or 2, and afterwards advanced mycosis fungoides and Sézary syndrome from the stage of the tumor, erythroderma, or lymph node involvement. And what I want to show you here is the N3 stage, which is very important because when you have when the patient has a N3 stage, it goes to 4A2 global stage. And you can see here the 5-year survival is going a lot down with 23% of survival from this stage compared to a very indolent behavior of early mycosis fungoides with only cutaneous lesions. So the lymph node involvement is very important to evaluate, stage, and follow in these patients. And you can see here other survival curves showing you the 4A2 stage that is very bad prognosis. These are data, retrospective data from 2010. And you can see here the dashed blue line showing you that they have the worst survival, these patients with N3 disease. So how do we stage and when do we stage the lymph nodes for patients with mycosis fungoides and Sézary syndrome? There have been some international recommendations. The pathologic assessment should include light microscopy with H&E staining, immunophenotyping, including immunohistochemistry, and in most cases now, either flow cytometry and molecular methods. Molecular methods are mostly clonal detection in the lymph node. I will show you afterwards that flow cytometry is not performed, at least in every center. It depends a lot on the habits of each center. And what is the standard for diagnosis, subtyping, and grading nodal lymphoma and in nodal involvement in mycosis fungoides? It has long been excisional lymph node biopsy, which is removing the entire lymph nodes. But in the recent years, and especially in my center, we have been using core needle biopsy a lot since years for both systemic lymphoma and also for cutaneous lymphoma. And I will show you afterwards the data regarding how we can use this core needle biopsy to stage. And it has now been admitted in the recent papers that a core needle biopsy may suffice to perform pathological staging. So what is the grading system, the staging system, for lymph nodes in mycosis fungoides Sézary syndrome? There have been before, in the 90s, a Dutch system and an American system, NCI-VA classification. They have been fused all together for the now used ISCL, the International Society for Cutaneous Lymphoma, and the EORTC that you may know, the European Association for Cancer classification. It has been simplified to N1, N2, and N3. This is the famous N3 that I told you about, stages. N3 is defined by the effacement, the destruction of the normal lymph node architecture by the tumor cells, either partial or complete. And you can see that in both previous systems of classification, this partial or complete effacement was associated with a very poor survival. Here you can see the Dutch system, and here the NCI-VA classification. Here is the survival. Whereas the N1 and N2, what are they defined? What is their definition? The N1 is dermatopathic lymphadenopathy. You know that in large numbers of dermatoses, you can have lymph node size increase. It's inflammatory reaction going to the lymph nodes, and it has got a very specific aspect on the microscope, giving lymphadenopathy without here lymphoma. Whereas the N2 is defined by the detection of some tumor cells in the lymph node, but without destruction of the lymph node architecture. So this has been updated in 2022, including also the clonal detection, and to put N1A or N1B, 2A, 2B. This is very descriptive and not really so much used in the practice, because, as I told you, the N3 is the thing of main importance. And either you find a clone or a clone identical to the skin or not, you may add the letter B to the stage. And what is defined also in these recommendations is that what has to be staged in these patients, what has to be biopsied. It is recommended to biopsy abdominal lymph nodes that are more than 1.5 centimeter of large diameter. This is according to the Lugano classification. Lugano classification is used in the field of systemic lymphoma and is applied also now to the field of cutaneous lymphoma. So you all know what is lymph node excision, and we'll show you shortly, because you will have afterwards a radiologist talking to you. So what is image-guided core needle biopsy for nodal lymphoma? Either it is by ultrasound or CT scan guided, and you can select the lymph node you will sample. You use a core needle. It's a coaxial technique. It's a quick and safe technique. It is less costly and give less complication, less morbidity than the lymph node excision. And what is of importance is the size of the needle. And I show you the difference between the 18G needle and the 14G needle sample. And of course, as a pathologist, you want to receive much more large samples because it would be easier to perform and more reliable to perform the staging. The ideal is 14G needle, and at least I would say more than 2 FFPE. It's fixed cores and some frozen samples for molecular techniques. The limitations is that in the field of systemic lymphoma, we know that more than 90% of lymphomas, you can make a correct diagnosis, but in some very difficult cases, it may be difficult and you may need a lymph node excision after the core needle biopsy, but in most cases, it is sufficient. And I would say it's the same for core needle biopsy in MF. I show you only here some examples. We have been performing these core needle samples for lymph node in MF since I would say 2010. And here is the first publication I made in 2016 regarding these biopsies on a limited set of 30 patients. And you can see here a typical N1 with dermopathic lymphadenopathy. In this dermatopathic lymphadenopathy, what you see is a reserve architecture using CD20. It's the B cells. You see here the follicles, the interfollicular T cells in CD3, and the presence of a lot of S100 dendritic cells indicating this inflammatory reaction of the dermatopathic lymphadenopathy. In the N2 stage, you find some clusters of atypical T cells, and I will define them afterwards more clearly. And here, the typical N3, really, it's quite easy because you see the destruction of the architecture using the B cell marker CD20. There is no more B cell tissue here, and everything is replaced. There is a complete effacement by the T cells that are atypical, and here CD3, CD4 positive. Well, this is a typical N3 stage. In this first study we made in 2016, what you can see here on top left is that the staging made on these core needle samples was quite predictive of the survival, especially for N3, as you can see here. So we detected well the patients that went bad. And it was the same for the presence of the clone with, versus non-clonal. What are the survival data that was available in the literature regarding lymph node excision? You can see here that it's the paper of 2010, the N3 patients in this paper, there were only 2% of the MF patients, but they had a median survival of 2 years. So we had about 1 year in our study. So it's quite the same. It's a very limited number of patients, but it's quite comparable. And very interestingly, recently, a Brazilian team tried to compare the stage you obtain on a lymph node core biopsy versus the excisional biopsy performed afterwards. And they demonstrated it's a small study with 10 patients, but still they demonstrated that using core needle biopsy, here is the end stage the pathologist made, and here is the end stage of the excisional one. It was almost the same, and you can see here the TCR analysis for clone and flow cytometry. The TCR analysis and the flow cytometry results were completely identical between techniques. And here is there was only one difference here for this one, and this is the limit of the core needle biopsy. It's because you use only a small size of tissue to assess for the architecture destruction. So here you can have some people you consider N2 and core that are N3 and excisional. We wanted to go a bit more in detail regarding the prognostic value of the lymph node biopsy. And you may know that other prognostic factors in mycosis fungoides in pathology are the large cell transformation. I give you some representative pictures of large cell transformation. The definition is more than 4 times the size of a normal lymphocyte in more than 25% of the infiltrate. In mycosis fungoides, it's about 5% of MF at diagnosis, 20% during of advanced MF at diagnosis, and more than 50% of advanced MF during follow-up. And in Sézary syndrome, we studied it in our center too, and it was 6% at diagnosis and 16% of Sézary syndrome during follow-up. So it's associated with poor survival. So in the study I will show you afterwards, we studied also LCT in the lymph nodes. And also we studied the value of the quantification of the clone. The previous speaker told you that we usually use a PCR technique to detect a TCR clone either in the skin or in the lymph nodes. And we have used since some years in our center a more, I would say, quantitative technique using high throughput sequencing techniques that enables you to quantify very precisely the percentage of the tumor clone into the complete population of the T cells in a sample. This technique had been used previously in skin samples by Adèle de Masson, which is people of our team, and she demonstrated in the skin, this is the skin here, that the frequency of the tumor clone was associated with survival in early mycosis fungoides, meaning that if you've got a large number of tumor cells in the infiltrate, well, you have a poorer survival than if you have less than 25% of tumor cells. So, having that in mind, I wanted to study these other criteria in the lymph nodes too. So we put all together retrospectively 100 lymph node core needle biopsy samples in our center using, of course, the traditional end stage, which is mostly morphological. I added also new immunohistochemical markers that can define the tumor cells sometimes. TOX is one marker that is used sometimes to detect tumor cells, tumor T cells. PD-1 that you may know is expressed by Sézary, but not very much by mycosis fungoides, KIR3DL2, and CD30, and of course also the proliferation index and the tumor cell frequency using the clonal detection by sequencing. Here is the example of what we see under the microscope. Here is the typical N1, here the typical N2, and typical N3. And, well, beginning by N3, it's easy. You use the CD20 marker to detect that there is only these small follicles here. All the rest of the biopsy is destroyed by T cells. And you can see here very well with the TOX markers that they are almost all tumor T cells. Nicely, in the N2, it's the beginning of the infiltration by the tumor T cells in the lymph nodes, and you can see here it's quite nicely depicted using TOX. Here you see aggregates of tumor cells, here also a bit of aggregates, but still they don't destroy the architecture of the B cells that is seen with CD20. You see nicely the small follicles here in the lymph nodes. Whereas in the N1, it's typical lymphadenopathy, dermatopathic lymphadenopathy, and you don't have any tumor cells using TOX. So here, how do I assess them? I first look at the CD20 to look for the architecture, then look at the CD3 to look for the T cells, how they are disposed in this biopsy, and afterwards I go to TOX to see if these T cells are tumor cells or not, and if they build aggregates and if they destroy the architecture, and afterwards do they express PD-1, and this is mostly the case in Sézary syndrome, most frequently than in mycosis fungoides. And here is the Ki67 I studied specifically in this study, and you can see that I had the impression that when the people are N3, meaning with a complete effacement or partial effacement by tumor cells in the lymph node, it indicates a very bad prognosis, we know. And I noticed that some people had higher Ki67, higher proliferation than the others. So I studied here that, and here you can see that it's a highly expressing N3, a highly proliferative one. So putting all together the results of the immunochemistry in these samples, well, we had 30% of N1, 22% of N2, 50% of N3. And you can see here that the Ki67 was really variable between patients with N3. Some of them are being very high, others being quite low. And another question you may have as clinician is, can we predict N3 stage without biopsy using only imaging? And in our cohort, the lymph node size by imaging, mostly CT scan, was not very specific to predict N3. You can see that it's using criteria such as a long axis more than 1.5 or product of diameters to detect N3 patients. Well, it's sensitive, but it's not specific, and this is mostly due to dermatopathic lymphadenopathy, because most of this dermatopathic lymphadenopathy, they have big lymph nodes, but stage N1. And here is the multivariate analysis regarding prognosis in these 100 patients. And what was associated with prognosis in this cohort of patients with lymph node biopsy? It was the frequency of the clone was quite associated, but I would say one of the strongest predictors of survival in this cohort was the high Ki67, high proliferation in the lymph nodes, in addition to the N3. And well, there is still work to do to know if we could go a bit further than the actual classification of N1, N2, and N3. Maybe we can have also adding some indication of prognosis using Ki67. And you can see here that you can discriminate people that evolved quite differently in survival using Ki67, especially in the N3. Some people are going very, very bad. They are the N3 people with very high Ki67. I just want to show you a very, very small and talk to you about the ProClipI data. ProClipI is a very large multicentric international project led by Julius Carisbrooke, that is here. She will maybe talk about that, and Yoon Kim in the United States. And just to have a small overview of the nodal data, this is a prospective study, international, to validate the prognostic factors in MFNSS. It's a large amount of work. More than 2,000 patients have been included. What I want to focus on here is the percentage of end stage in this entire cohort. Most of the patients you will encounter with MF, they don't have clinical, palpable or detectable on CT scanners lymph nodes. 6% of them in this cohort have had LN biopsy, lymph node biopsy, but here you can see that even in these centers that are treating patients with MF, we still have about 12% of patients with NX. And what is NX? It's patients that have a detectable either clinically or on radiology lymph nodes that are more than 1.5 centimeter of large diameter, but don't have biopsy, so you don't know their precise stage. And it's very difficult to use these patients for in studies and follow them, because finally you don't know well if they are clearly tumoral in the lymph nodes or not. And this is only something I want to tell you. It's important to biopsy the patients with adenopathies in the field of MF, because you will much more precisely stage them. Well, so very shortly, ProClipI, we have 123 biopsies of lymph nodes, most of the, quite separated in WEN 1 and 2 and 3. And we still have work to do to precisely study maybe Ki67 in this cohort and the prognostic value much more precisely. And work has been already published by Julia Scarisbrick and others investigators of the PROCLIPI study regarding the lymph nodes in the early stage mycosis fungoides patients, the one that are the most frequent, the one you will see as diagnosing them, the one with patches and plaques. And should we be doing CT scans to detect increased lymph nodes in these patients? Well, it's an open question, but in this study of the PROCLIPI patients, finally, when you have patients with only patches and plaques, T1, T2 patients, almost 18% of them, if you do CT scans, will have increased sized lymph nodes, and most of them will be, of course, N1 or N2. They won't be very fully tumoral lymph nodes, but still, it could upstage them to the stage 2A. So it's still an open question. Which patients should you do CT scans to? And in the field of the International Society for Cutaneous Lymphoma, I did a very short survey of in centers that are treating patients with CTCL to know what is their finding. What do they do for patients for lymph nodes? Because as I told you, core needle biopsy is an option, but it's not done by all centers. And here are the results. There was 12 centers responding, and at least 1/3 of them are doing core needle biopsy really on a regular basis, and half of them are doing core needle biopsy, and some of them doing both. And do they include the stage in the pathological report? Most of them do, and it should be put in the report. You should ask for that. It's much more diverse regarding flow cytometry. Sometimes it's not performed, and it depends highly on the countries, because some countries are doing a lot of flow cytometry in lymph nodes, especially US centers, but not so much in Europe, I would say. Whereas clonality is, of course, much more done on a regular basis. And as a clinician, what should you expect in the pathological report of a lymph node biopsy? Of course, you should know the type of samples you've had, excision core needle, the size of the atypical cells, and the presence of not of a large cell transformation, because it's important for prognosis, but also to choose the treatment, and the minimal set of phenotype, and the final diagnosis. Is it dermopathic lymphadenopathy, N1? Is it LN involvement by MF or Sézary, N2 or N3? Is there LCT, as I told you, and the stage? I think it's important to have precise staging of the patients, because you will follow them differently. Maybe you will treat them differently depending on the stage. So, finally, where do we stand now for lymph nodes in MF Sézary? I would say LN staging is a very important prognostic value. You should, of course, follow the patients clinically for the superficial lymph nodes, but I think imaging has a strong place, and still it has to be defined, which is the threshold of the patients you should perform CT scans to. Of course, I will suggest to biopsy all patients with LNs more than 1.5 centimeter as per recommendation. And this is easier if you perform core needle biopsy, because as I told you initially, it's much less costly, it's easier to organize, you do it very fastly, the patient does not need to stay at the hospital, it's very fast. But the criteria are choosing a representative lymph node, of course, performing sufficient core needles, and I would say most important thing is to have a willing team to do that, a radiologist which is keen to perform this core needle biopsy, and a pathologist who agrees to interpret these small samples and to perform the stage on that. And the main point you should keep in mind is detecting N3 stage. It's a major prognostic event in the mycosis fungoides caesare course, and the definition you have to know is destruction of the architecture by lymphoma cells, and maybe we could add some refinement to the prognosis using new criteria, but further studies are needed. And I will, with that, close my talk. Thank my collaborators here at Saint-Louis Hospital in Paris, at the cutaneous lymphoma clinic, especially Professor de Masson and Professor Bagot, the dermatologist, and thank and greet all the friends and colleagues I work with at the different international organization of cutaneous lymphoma, Julius Carisbrick, Jan Kim, Alejandro Gru, my colleague, a pathologist in US, Evangelia Papadavid, of course, and Emilia Odak. And I thank you.
Oh, thank you very much, Maxime, for this excellent lecture on lymph node pathology and the use of core biopsy. Unfortunately, the radiologist that is performing our core biopsies, he just texted me. He's in the emergency room. He had a kind of heart problem, and he's not with us at the moment. I hope he's recovering this event. We're fortunate we have somebody at the hospital I work at, the university hospital, that does the core biopsies, and we take these biopsies from the patients that have enlarged lymph nodes, more than 1.5 centimeter, and we send them to the pathologist. So our pathologist, Leonidas, is here, Leonidas Marinos, so he can comment on that. He will comment on that. And I mean, the message that you give to all of us is that so important to biopsy enlarged lymph nodes, even if we feel that there might be dermatopathic, because then it's better to perform a core biopsy, because it's an easy procedure. It's like it's a punch biopsy. However, you need a specialized center or specialized physician, but you can save somebody from keeping them for a long time without any aggressive treatment. And as you said, N3 is a predictive prognostic factor. It's a very bad prognostic factor for patients with MF. It's interesting. We don't do talks, because you mentioned this during the last years in your lectures, and I don't know how important. I mean, I realized that it's very important, but it's not in the standard.
It facilitates the diagnosis for the pathologist. Really, it's a nice marker to help detecting tumor cells and detecting the small aggregates, especially for N2 stage. And I would say when you combine the morphology tox, well, it's not 100% sensitive, but in most cases it works. More than 90% of cases are tox positive. And when you combine that, we have the chance to have this quantification of the clone. So we have the tox, so you can see, well, there is small aggregates, and I do the TCR sequencing, and I detect like 5% of clone. Well, it goes well. You see that indeed there is a small population of the tumor cells, but it does not destroy the architecture of the lymph nodes. It gives more confidence in providing the stage on a small core needle biopsy.
Yeah. I don't know if there are any other question from.
But indeed, I would say that now it's the acceptation of this procedure by the radiologist, but in the field of cancer, in all types of cancers, we go to miniaturization, I would say, and to more small samples. So, well, it should be, it's the nature of the progress to go to that, because it's less invasive than open surgery to make diagnosis. And I would say that the question now is to which patient should we perform CT scans in early mycosis fungoides? And this is the question. This is, do you have to perform CT scans in all MF patients at early stage, or only patients that have plaques, or plaques in more than 10%? Well, there is no rule for now, but it's a work surely that we should make all together to provide recommendation.
Yeah, you mean even
to detect, the interest is detecting early the patients that may go bad afterwards, and the one that clearly may go well longer.
Yeah, well, this is a very interesting question, and I think we try to analyze our patients that we had some ultrasound work on them. We try to perform ultrasound in every patient that has a possible palpable lymph node, even if it's not 1.5 centimeters. And we're currently collecting this data, comparing to CT scans and core biopsies, and see what the result will be. And it would be interesting to see the size of lymph nodes, if this correlates with a result from the core biopsy. But I mean, I think that the consensus is that we don't really do any CT scans in patients that we don't feel any palpable lymph nodes. So no palpable lymph node. There is no recommendation for a CT scan in early stages. And I mean, the ultrasound can be a method that can be used. And I think also it's in some national guidelines in Europe. They have the ultrasound as a method for imaging method.
Okay.
Yeah.
So I would like also to congratulate you for this excellent presentation, Dr. Battistella. I would like to ask you something. The difficulty is usually, as we have experienced it all these years, in the intermediate stages, N1 and 2, where we have small clusters of cells that cannot be detected easily with immunohistochemistry. Size, I will agree with you that if we have a large size, okay, we can go along with typification of the involvement of the lymph node. But as you know, most of the times, cells may be very small and are particularly difficult to discern them morphologically. So has it been your experience too that these stages are more difficult to do in core biopsies? And so, because I was always a pro for a surgical biopsy. But now I see that there is a field for this with TOX and quantificative methods, moleculars.
Yes, indeed. Thank you for the question. Indeed, when there are large cells, it's easy. But for most of the cases that have small to medium atypical cells, and I would say that the great help is the positive markers, because the loss of CD7 or other things, it's difficult to assess a loss in a diffuse way. So indeed, TOX. PD1 is a good one also in Sézary, but it works in Sézary, but not so well in MF. And of course, the quantification of the clone. This is also a very good help. When I find 80% of clone, or some cases when you have more than 40-50% of T cells that are clonal, yes, it's a great indication of the involvement of the lymph nodes. So these newer techniques, they facilitate the use of the core needle biopsy and to be more confident.
Thank you.
So if there are no other questions, if there are no other questions, then we would like to thank you very much.
Thank you.
hope to see you soon, next week.
So do I.
And it's a great pleasure. I don't know if you want to stay online. It's to introduce Jackie Hopkins, who is a dermatopathologist and a dermatologist. And she has great experience in dermatopathology and cutaneous lymphomas. And she has been working in several institutions in U.S., great hospitals like Hopkins. And she was at the Ackerman Institute, and now she's working in sorry, I can't.
I have a sign for it, so
Okay.
it's okay.
And Jackie will make an overview on the differential diagnosis between inflammatory diseases and mycosis fungoides.
Kalimera. Did I do that right? So I'm grateful that the speakers before me were able to give a nice outline of the general diagnosis of mycosis fungoides and Sézary. They did the hard job, but now I'm going to tell you all the problems that can happen when all those rules are broken. So I also want to thank Leah for inviting me again. I enjoy this conference, and I had a very nice time when I was here last time, and hope to have a nice time this time as well. So how much time, Leah? We have, because now it's short.
It's fine.
Okay.
40 minutes if you want.
Okay, all right. So let me just put these on. So I'm at a program called Geisinger. I've been in various places, as Leah said. So Geisinger is a huge institution in a tiny little town in the middle of Pennsylvania. We have 8 dermatopathologists. It's a very robust dermatopathology program. We're located a couple hours from New York and a couple hours from Philadelphia. So I actually live in Philadelphia and sort of nearby. I don't live in the town, but it looks very pretty, don't you think? Not as nice as Greece. So good. I don't have to go over the different types of lymphoma because you heard a little bit about these. But it's going to be important to know that there's a lot of overlap with these. And it'll be important to differentiate these because some are aggressive, some are not aggressive, and you don't want to get mixed up. And that has happened many times. And mycosis fungoides, as you know, has a very specific type of clinical presentation, patches, plaques, usually double-covered sites like the hips, inside the arm and the thigh, indolent, and it has a very specific type of histology, epidermotropic, usually CD4 positive. But where the pitfalls can arise is when it presents in a way that we don't expect. And over the years now, because we keep giving lectures, people are more aware of some of the variants. But before, the variants used to be missed, and so we would not call something lymphoma because it didn't fit the criteria. So I'll go over a few of these. And again, it was nicely outlined how to make the diagnosis. Clinical pathologic correlation is really critical. If sometimes you can have a patient who you really think has mycosis fungoides, but any pathologist, as good as they are, still can't give you the diagnosis. In that situation, you can try to get PCR. Sometimes if you take PCR, 2 samples and send it for PCR and they match, that's more specific for mycosis fungoides. As you heard, high throughput sequencing or next generation sequencing can be more specific, and that can make a diagnosis of mycosis fungoides when PCR itself won't. So those are different things you can do if you're having trouble making the diagnosis. You can rebiopsy, always have a conversation with the pathologist, and I'll show you a few other things that can be helpful. So here's your classic mycosis fungoides. It's epidermotropic. You can see here that the lymphocytes are just they're sometimes epidermotropic into the epidermis, but sometimes they're just hanging out around the epidermis, and that is still, in a sense, epidermotropic. You can see these Patrier microabscesses here, but they will occur usually a little later. So 20 years ago, when I first started, people weren't calling things mycosis fungoides because that was what was expected for the diagnosis, but now we know that that comes up later. We like to look for cells with halos around them, and this is hard to see, but they're very notched, and sometimes it looks like there's a slice in them because it's like a brain. It's cerebriform, so if you just see it in one plane of sections, instead of being a round, smooth circle, it's jagged. So we look for those cells in the epidermis. There are different ways that the lymphocytes can involve the epidermis. I like to look for the beading, so they're on the epidermal side of the epidermis, not at the base like in lupus. And so beading along the base of the epidermis is also very helpful. So here's just an example of mycosis fungoides versus eczema. And a lot of times eczema is going to be in the differential diagnosis. I think mycosis fungoides tends to have a different pattern of the epidermis. You have these skinny rete or slender rete, sometimes juxtaposed to fatter rete, whereas eczema, that's, we're rubbing it, so that's the one that gets very broadly acanthotic. So that's one of the differences, and also more spongiosis, which I can show you. So here's an example of mycosis fungoides up here. It doesn't have as many of the skinny rete. They won't always, but that's a sort of a helpful clue. But I don't know if you can tell, there are these little lymphocytes with halos around them, and there are a lot of them in here, but there's no spongiosis, so there's nothing that's calling it to go into the epidermis. Whereas here you have a lot of lymphocytes, but there's also some fluid in here, and so you have the spongiosis is out of proportion to the amount of lymphocytes that are here. And here, this is an example of a lichenoid tissue reaction. Instead of having the lymphocytes on the epidermal side, they're actually obscuring and destroying the basal layer. So this is a lichenoid tissue reaction. And when you see that, that's more, even though the cells can look atypical, that's going to be more in favor of a lichenoid dermatitis. So in general, you don't have these epidermal changes, lichenoid dermatitis and spongiosis in mycosis fungoides. But again, that can be one of the pitfalls. We can also look at the stratum corneum with spongiosis. There's usually going to be some serum and parakeratosis and inflammatory crust. And that's less common in mycosis fungoides. The epidermis usually is very sort of compact, and so you just see sort of a thin orthokeratotic layer. Again, I mentioned spongiosis being out of proportion to the exocytosis, and you can see here, you're always going to find a little bit of spongiosis if you look carefully, but there's not a lot. But you have the lymphocytes with these sort of jagged outlines, which are hard to show here. Then the other finding that's helpful is this fibroplasia of the papillary dermis, which I can show you later. So again, a lot of exocytosis, so you could say, well, maybe it's epidermotropic, but the lymphocytes are usually a little smaller. Again, there's a lot of spongiosis. And here you can see there's uniform atypia. A lot of these have these perinuclear halos. They're hyperchromatic, they're a little larger. This is an example of allergic contact dermatitis, and you can see these cells here are very atypical to me. You could take these and put them in a biopsy of mycosis fungoides, and it would fit just perfectly. But it's admixed with some rounder, there's my arrow, small, round, smooth lymphocytes. Sometimes they get a little bit stretched. So it's not the only cell here. So when it's sort of mixed in with other reactive cells, then that's also a feature more of benign. Again, these perinuclear halos are helpful. A lichenoid dermatitis will sometimes have some vacuoles, but here the vacuoles all have a lymphocyte in them, so they're really the halos, but we can refer to it as lymphocyte in every hole, so that's helpful too. We look at the pattern of involvement. I talked to you about the beading, which is very helpful. Sometimes it just sort of peppers the bottom of the rete as opposed to just beading. Sometimes it can just be very pagetoid and show lymphocytes all over the place. And then I mentioned the Patrier microabscess. Within the microabscess, we can see Langerhans cells, 1 or 2, but it shouldn't be filled with Langerhans cells. So when this collection of mononuclear cells is higher up in the epidermis and sometimes spitting out, that's more an example of a Langerhans cell microabscess. And so they have smoother, bean-shaped or Rennes-shaped nuclei and a little bit extra cytoplasm. They're usually sitting a little higher up. Those are supposed to be more in inflammatory eczematous processes than mycosis fungoides, but you can sometimes see them in mycosis fungoides. And then the pattern of the dermal inflammation, as I mentioned, it likes to hug the epidermis. If you have a lot of lymphocytes around the vessels, that's a little bit less typical of mycosis fungoides, unless in another section, maybe there's a hair follicle there, and that's why it happens to be there. So the wedge shape goes more with conditions such as lymphomatoid papulosis or pityriasis lichenoides, both of which can show some atypia that looks like mycosis fungoides. So here are just two different examples of how the lymphocytes stay close to the epidermis. It's band-like, but it doesn't erode the epidermis like lichen planus would. So lichen planus is also band-like. And here it shows the skinny reedy that I mentioned earlier. And this is in contrast to pityriasis lichenoides on the right, where you have that looser scale crust and parakeratosis, and you have more involvement of the lower papillary vascular plexus. And I mentioned the dermal changes. You have fettuccine-like fibrosis of the papillary dermis. In a chronic contact dermatitis, you get lichen simplex chronicus, so you get vertical orientation of the fibrosis. And then sometimes you'll get more edema as opposed to fibrosis. Sometimes, as you heard, well, not sometimes, often the immunophenotype will help us make a diagnosis of lymphoma. You want to look at the cells that are doing the badness. So here, the epidermal cells are the ones that are abnormal, and those are the ones that are positive for CD4 much more than CD8. And you can see in the dermis, there's going to be a mixture. So early on, if you're just sort of not paying attention to just looking at the biopsy, you might think that they're equal, or CD4 is barely increased compared to CD8. So we try to look to see how much skewing there is of CD4 versus CD8. So here you can see CD3 and CD4 are about equal. CD8 has barely any lymphocytes, so there's a marked increase in the CD4-CD8 or helper-suppressor ratio. And you can also start losing expression of some of the T-cell antigens that should be present on lymphocytes. So CD7 is non-specifically lost, but when it's completely absent or almost completely absent, that's sometimes very sort of suspicious for mycosis fungoides. And loss of CD5 is even more suspicious, almost specific for mycosis fungoides. So just to sort of summarize, it's usually an increase in CD4 compared to CD8, but you have to be careful because you can have CD8 lymphocytes instead of CD4, and you can have them both be positive or you can have them both be negative. And so that's where you can run into problems in terms of making the diagnosis wrong if you're not paying attention. And then CD4 can also hit Langerhans cells. So sometimes it looks like it's very CD4 positive, but really a lot of those are the Langerhans cells. You have to sort of minus that. And as I mentioned, loss of the maturation T markers is helpful. But otherwise, remember the pitfalls. So I'm going to talk about pitfalls throughout most of this. So this is an example from the literature of a CD4 negative, CD8 negative mycosis fungoides. You can see on the right, they look, if you're not paying attention, like they're both about equal. But compared to CD3, you can see the beading along here. Those cells are completely absent in both of them. So this would be a double negative mycosis fungoides. This is Dr. Hodak's group who published this, and they said that a lot of these, some of their cases were cytotoxic, and some had some CD30 and CD56 expression. But they were all found to be clinically indolent mycosis fungoides. Now the thing is, double negative CTCL sometimes can be gamma delta and sometimes can be some of the more aggressive lymphomas. So you do have to always correlate it with the clinical presentation at the time and also see how quickly they're progressing. All right, so the pitfalls can be in various ways. You can have lymphoma, the wolf, acting like a benign sheep. So let's say it looks like pigmented purpura, and the clinician thinks it's pigmented purpura, gives it to us, and we give them back pigmented purpura. But you have to know that sometimes mycosis fungoides can look like pigmented purpura. And also some of the other more histologic mimics I'm going to go over. In contrast, you can also have some benign conditions like lichen sclerosis, sometimes herpes zoster, and rarely herpes simplex can have some abnormal findings that look like lymphoma. So you can have benign conditions mimicking lymphoma. And then you can have lymphoma missed for a lot of other reasons. It can be very, very subtle histologically and clinically. You can have immunohistochemical findings that can be misinterpreted, like I mentioned earlier. You can have a PCR be negative, and if you don't understand that you can have false negative PCRs, then you could sort of mess up that way. So there are different ways that we can mess up. I don't know how we're still functioning, knowing all these problems we can have all the time, but we just power through. So this is one of the first ones I had many years ago. It was MF versus eczema. And how many think this is MF? How many think it's eczema? Well, all right, I was just starting and I thought it was eczema. But then I talked to the clinician and he told me this is the buttock and there's this lesion, and the lesion cleared up with triamcinolone. In fact, that's what he had told me, response to triamcinolone, when it makes sense. But the same one kept coming back. So it's not like he's got eczema all over that just keeps coming back anywhere. The same spot comes back. And those of you who take care of lymphoma know that it's the same one that comes back because triamcinolone clears it, but it won't sort of keep it away forever all the time. So after talking to the clinician, I cut more levels and I looked very carefully. I told you one of the pearls is to look for these irregular cells here. And then after cutting levels, I found collections of these irregular cerebriform cells. And so I fell into the pit because I didn't realize how subtle it can be. So, and it's good, again, if you think they have lymphoma, talk to the pathologist and see if they can sort of get the diagnosis out a little bit better by doing levels. This is a guy who had a patch on his thigh that was thought to be maybe nummular eczema or maybe pigmented purpura. And so, first of all, do you guys think this looks like mycosis fungoides, or do you think it looks like a benign diagnosis? Benign. It looks benign, doesn't it? I think it looks benign. So here's our low power. Now, I have these special glasses that allow me to see lymphoma a little bit better. And so I'll tell you what I see with my glasses. I see some skinny reedy and areas of flatness. And I see lymphocytes that are sort of band-like up here. There's not a lot around the vessel. So already I'm a little bit suspicious. Going closer, you can see there are, you want to say maybe there's some vacuolar change here, but then there are a lot of lymphocytes in these holes with halos. So I'm already a little bit suspicious here, but wondered, could this be pigmented purpura? You can see that because there's a lichenoid variant of pigmented purpura. And so same for iron, and there's iron. So pigmented purpura, right? No, because I'm giving the talk. So you see here a lot of the lymphocytes are hyperchromatic. Each of them are in these little vacuoles, and they really are a little bit bigger. People say, oh, it's this many microns. I mean, do you guys really measure the lymphocytes? We don't. But after looking at something so long, you start to know what's an atypical cell and not. But I'll just tell you, these are all a little bit bigger and darker. And then using my special eyeglasses, I can see that the lymphocytes are beating along the base of the epidermis here. And so I'm almost, hitting a home run here. And then you can see the same sort of darker cells here, very hyperchromatic, very atypical. So this, I thought, just by H&E alone, could be mycosis fungoides. You see CD3, CD5, and CD7, complete loss of CD7. And if you look carefully, the beating, I like CD3 because it outlines the atypia. And you can see, if you pay attention, that that's absent in CD5. So that's very suspicious, if not, right now at this point I could just stop and say it's mycosis fungoides. CD3, CD4, and CD8, at first glance, doesn't it look like CD4 is more than CD8 or at least equal? But then if you look carefully, it's negative. These little beaded guys are negative for CD4. And so you can see, if you really pay attention, and this is more obvious, but sometimes it's more subtle, that the CD4 cells are not staining. And you can see that CD1A highlights a lot of Langerhans cells, some of which are sort of correlating with the CD4 staining. And so this is a diagnosis of lymphoma, but we had to put a lot of things together, looking at the silhouette, paying attention to the cells, looking in different areas, paying attention to the immunophenotype. And you could get PCR in this also to confirm it, but if it's negative, you might still call it, right? Sometimes it's good to get PCR to show a clone, and then you want to see, well, how much of the stuff on his body is his MF and how much is the other, and so you can maybe get a few samples just to get an idea of how much lymphoma he has or she. All right. Talking about some of the variants. So as I mentioned, the variants, if you aren't aware of them, you could not call something lymphoma when in fact it's just a different presentation. So a lot of these now people are familiar with. The hypopigmented type, which often is seen in the darker skinned patients. Palmar-plantar, which I find very difficult to differentiate from hyperkeratotic eczema. And I'm going to go briefly over some of these other types. So as I mentioned, that there's a pigmented purpura variant. So this looks exactly like pigmented purpura, and the annular variant. It can look like the more diffuse Schomburg's variant. It can really overlap with all, but this is on her abdomen. This is suprapubic. So pigmented purpura really shouldn't be on the abdomen. It usually is on the lower legs. And so that's a clue that it might be mycosis fungoides. Sometimes the biopsies, depending on where you take it, could look like pigmented purpura. But again, looking closely, you see all these notched lymphocytes in the dermis. And then sometimes with the pigmented purpura type, you got to use all your tools. And so this, you also show that it's increased CD4. So that one can be a little bit difficult. This one's not quite as difficult, but just another example of pigmented purpura. Again, once the diagnosis is more established clinically, it's not the very early ones, probably I wouldn't try. But once they have these plaques, you can usually show that the immunophenotype is abnormal. This guy years ago I saw who had little bumps. I used to call him guttate MF, but now there's a described variant that they named papular MF. But he has a lot of these little bumps all over his body, more his truncal area, the same area where MF would be. And he had histology of mycosis fungoides, but little baby versions of it. This is where taking two PCRs of two different ones and showing that they're the same is going to be helpful. This is from Dr. Hodak's group. She's got a lot of patients that she collects and shares them with us in the literature. And this is an ichthyosiform presentation. Looks just like ichthyosis. And they saw that some of these patients, that's just how their MF presented. Other ones had ichthyosis, an ichthyosiform dermatosis, and had a follicle center, or this says follicular, but it should be folliculocentric mycosis fungoides. And then some had some MF and then some ichthyosis. Remember, ichthyosis is a perineoplastic presentation, so some people can have lung carcinoma with it, some can have breast, and probably some can have CTCL. This is a guy who had sort of a lichenoid dermatitis on his biopsy, and he had all these pigmented areas on his trunk and arms. And on review, he actually had mycosis fungoides that was more of a lichenoid presentation. In dark-skinned patients, it can look very, very dark. You can see here that sometimes it can have, like I mentioned, a lichenoid presentation that can look like lichen planus pigmentosus because you have very hyperpigmented areas. You can see that this person had the atypical cells of MF. And in fact, hyperpigmented MF is I've seen it for years, but in the literature is, sort of brought up as being another subtype. And you can see how it could be missed. In this group, accidentally called it lichen planus pigmentosus at first, and then other biopsies showed more diagnostic mycosis fungoides. So be careful with that hyperpigmented variant. I don't know if you guys see a lot of patients with darker skin, but at Geisinger, they don't see it, and so it's taken them a while to get used to what skin looks like when it's erythrodermic. And so with Sézary syndrome, I'm not going to talk a whole lot about it, but first of all, you just have to know that that's sort of what the problem is, because the clinician might just say, oh, dry skin or something. And then the other problem is the diagnosis is often missed because the biopsy won't show mycosis fungoides. A lot of times it'll be spongiotic, mostly perivascular. And so anytime, and they keep sending me things, rule out Sézary, and because they're erythrodermic, and I keep telling them, you know, sure, give me this, but you have to do flow cytometry and look at the blood and look for the abnormal cells circulating. They're identified by an abnormal phenotype that's usually high in CD4 positive, CD7 negative, high in CD4 positive, CD26 negative. And, you know, there are the different categories. You know, B2 is complete Sézary, B0 is nothing, and then there's that in-between variant. But either way, you have to look at it by blood to make the diagnosis. Send in the skin to the pathologist, that's also still good, but don't forget the skin, or the blood. All right, here are my special glasses here. So the histopathologic variants are also tricky. So look at how striking this lichenoid tissue reaction is, all these big colloid bodies. This is a lady also when I was first starting to see patients. And they thought it was lupus, but look at, maybe you could say lupus here, but she years ago got radiation for CTCL, so she has definite CTCL, but this really striking lichenoid tissue reaction. The other one that's very, very difficult to diagnose is a spongiotic variant. So there can be really prominent spongiosis, and as I told you earlier, that you shouldn't have spongiosis for MF, but you know, that's a way to fall into the pit if you only rely on that. So here's a biopsy, tons of spongiosis, little, you know, vesicle formation, but you can see peppering of these darker cells throughout. So even though there's a lot of spongiosis, there's still a lot of epidermotropism. Spongiotic MF, in my experience, is almost always CD4 positive. I did have one guy who was double negative many, many years ago, and my guess is he might have had gamma delta at the time or something else. But because he progressed quickly. But so this will be helpful, and a lot of times maybe it's positive because it's more advanced by the time, you know, they get diagnosed. This is the first lady I saw with spongiotic MF. She came in with this, and she had, this is the biopsy I showed you, marked spongiosis with vesicle formation. She's the one that had the heavy peppering of the lymphocytes in her skin here. And she also had some CD30 positivity, so I wondered if she was an early transformation. But she also had some patches on her cheek, in her arm, and on her buttocks, so she clearly was mycosis fungoides. And then this was just a manifestation, a little bit more of a plaque stage. So it's rare, the spongiotic variant is probably less rare than we realize. There have been some literature that has been published on spongiotic MF, and when I look at them, there's a little spongiosis in it, but this like really spongiotic change is not common. I've seen it a lot with follicular tropic mycosis fungoides, and what you can do is you can try to, you know, do the double clone, the double PCR, and see if you can sort of get the diagnosis that way. I mentioned hyperkeratotic eczema that can be difficult to differentiate from palmar-plantar MF. They both have exocytosis of lymphocytes. And the title of these authors' talk is really the conclusion. Clustered intraepidermal lymphocytes and Langerhans cell microgranulomas are seen more in the hyperkeratotic eczema versus psoriasis and MF. So I'll just show you that here. So this is their example they give. So these Langerhans cell microabscesses up here, and a little bit of exocytosis that overlaps with MF. And they mentioned thin suprapapillary plates, which I don't think shows up here very well. It's a little tangentially sectioned. But they, you know, try to find something for us to use. I just find that this is very, very difficult, but it's something that I can use when I'm trying to differentiate. This is a guy who I saw later, but I went back to put his story together. And here's his arm, some rash on his arm, some on his back, a little bit on his, around his face and in his hair. And here's his biopsy, acanthosis, tons of spongiosis, not a lot of lymphocytes. If they're here, they're not very atypical. And so that was called spongiotic dermatitis. And 100%, that would be spongiotic dermatitis. So you can't be the Monday morning quarterback. Do you know what that means? Okay, so like we have a lot of, how is that used? the game is played on Sunday in football, but then they mess up. So then on Monday, they talk about the game and how they screwed up, and they should have done that, and they should have done that. That's the Monday morning quarterback comment. So we're not going to do Monday morning quarterback on this. But he had a second biopsy. This is the one I got. A lot of spongiosis again, but I was really struck by how many lymphocytes were sort of collecting around the base of the of the hair follicles. And you can see CD4 really highlighting this. And this is, I think, CD5 or 7 or 8, or it could be any of them. But you can see it's really lost some antigen presentation. And so this is him. What happened was over the years, he just kept getting more biopsies, and I saw him here. So he really progressed. And then the biopsy I had was from somewhere around here. And you could see, I went back and I stained this, and you can see that it had the same skewed, I think this is maybe CD4 and CD8, the same skewed immunophenotype. And so he taught me a lot in that, and there are a lot of eosinophils too, so that's why they call it spongiotic dermatitis. But the follicular tropic type of mycosis fungoides can have a lot of eosinophils, and really you have to look clinical pathologic correlation and then rebiopsy if their rash isn't clearing. I think follicular tropic mycosis fungoides is tough for a lot of reasons, because prior to the last several years, people weren't aware that it's not MF. You know, MF is usually the butt, right? This is more head and neck. It's very itchy. Sometimes, like, he used to have hair here, but he doesn't have hair because he has bad mycosis fungoides that made it all go away, and he's itchy, so he looks like eczema. So between clinical looking like eczema and then histology having spongiosis, it can be a disaster, I think. Also, if you get, even if it looks like a tumor or something, for us, under the microscope, it can look like reactive lymphocytic infiltrate, especially if you have a lot of eosinophils. Sometimes they can present with comedones and acneiform lesions, and then they pop and they look like reactive, just reactive granulomatous dermatitis. So it can really be sort of treacherous. And so even though in mycosis fungoides, you shouldn't see a lot of eosinophils, remember in the follicular tropic type you can. And so this person actually, the follicular tropic type and Sézary, and so this person here, they reported having 1 or 2 EOs, a couple EOs here and there, and then they turned out to have mycosis fungoides because they had erythroderma. Here's another example of a case in which the biopsy doesn't look like much, very spongiotic, probably a little Langerhans cell microabscess in another cut. But looking for levels, because I knew the patient had a lot of bumps, looking for levels to find the hair, you can see that the hair is infiltrated by lymphocytes. And if I do CD4 and CD8, the ratio is really quite high. So this person ended up having follicular tropic mycosis fungoides. Here's another person, the same thing, spongiosis, CD4 much higher than CD8, cutting levels, there's a follicle, and this person also has follicular tropic mycosis fungoides. This could be another problem. This is a shave biopsy, and you can see how spongiotic it appears. But this is just to let you know that if they have papules as part of their presentation, at some point try to take a punch. I don't know if you guys do a lot of punches. My group shaves everything. I got to tell them, okay, just take 2. Give me a shave, then also give me a punch. And so here you can crash and burn if you sort of didn't do a punch, which they end up doing. I just did this to have the effect. Now, that probably has some mucin. I didn't check for mucin in that, but mucin within the epidermis can look like spongiosis, and you can highlight it with a mucin stain. And that's been shown to be associated with mycosis fungoides, and in fact, a lot of those people had follicular tropic disease, sometimes even widespread disease. And here, this shows how if you stain it with PAS, if it's positive, that's going to be more eczema. And if it's positive for colloidal iron, that'll be the mucinous vesicular. People like to put different names on it. But so that's another little clue you can do if you think there could be mycosis fungoides. This is another possible mishap. You see this person with these little sort of lichenoid papules. I've seen this submitted as rule out lichen planus, and it doesn't really show much. if you look at that, there might be some lymphocytes there, and we're going to look a little closer here because it was actually a punch biopsy. I just showed you what the top would look like. And this is syringotropic mycosis fungoides. Clinically, it doesn't look like anything. It's easy to take a little shave of that, but you'll completely crash and burn if you do a shave and don't look at the deep eccrine glands. This is another subtype which drives me nuts because there's no epidermotropism. It's interstitial mycosis fungoides, and it has overlap with inflammatory morphia. I had one I just finished before I left that I was waiting for the PCR to come back because it was interstitial mycosis fungoides versus morphia on the upper thigh, so the same location and everything else. Granuloma annulare can also have some overlap, but it's going to maybe have more histiocytes, maybe more mucin. So this subtype has been described by a group of people. Tironi is the lead author. They looked at patients. They knew that these were mycosis fungoides because the patients had other lesions of mycosis fungoides. So that's helpful. If you're going to make a new subtype, you got to prove it. And you can have clonality and morphia, so you have to be careful. You can't just say, oh, it's clone positive, therefore it's mycosis fungoides. But they noted that sometimes they had TIA markers, so they were cytotoxic, some of them. They weren't always CD4 positive, and so some of the other features are different than regular mycosis fungoides, but these patients still had an indolent course. This is something from the literature in which they thought it was interstitial mycosis fungoides. Yeah, let me think. Yeah, so it was really morphia, but initially thought it was interstitial mycosis fungoides. So that even in the literature, there's confusion in my own head and confusion by other people. So just be aware of that subtype and that it can be difficult to diagnose. So there are a lot of mimickers, so benign things that mimic mycosis fungoides, and I think some of them, this morning I saw somebody gave a talk, mentioned annular lichenoid dermatosis of youth, and that's one I don't have an example of, but I saw that was already presented. And I'm going to show you a few others. So Leah, keep going, or
I think about 5 minutes more if you want.
maybe 10 to okay. So basically, drug-induced pseudolymphoma can be B or T, can look like nodules, can look like MF. Just a drug causes the T cells to do weird things. This isn't just an example to show you how epidermotropic it can be. It almost even looks like it's beating, but the lymphocytes are small, no papillary dermal fibrosis, nice, basket-weave stratum corneum, some sponge. And so different things like that help us say it's drug. Immunophenotype is pretty much equal, 4 and 8, or maybe only a little bit more 4. CD7's not too lost. And then sometimes you can imply a certain medication, sometimes you can't. There are some classic ones, the anti-lipid medicines, the antihypertensives, the psychotropic drugs, antidepressants. Those are some of the big players. And it's not like a drug rash where you take a drug, then you get MF. It's usually, months before that you've had it. And so it also will take a little bit of time when you stop it to have the rash go away. You guys are familiar with the MOGA rash. So mogamulizumab is a medicine used for Sézary and MF. And most of these patients who are on it get a rash. And the rash can look like mycosis fungoides. And the thing is, you don't want to stop it because it might indicate that it's working. So it can be a good thing, but the hard part is knowing if your MF is getting worse or if you have a MOGA rash. And so just be aware that that is a phenomenon out there. Just to show you some examples here. These are just some clinical examples. It can look like all sorts of things. But what they have their MF, and then all of a sudden they're getting new lesions. And then you can see histologically it looks like MF. Sometimes it'll be a little bit granulomatous. PCR should be able to help exclude this. Here are just other examples here with some granulomatous features. Lichenoid keratosis, just a little single bump. This is something that we see looking like mycosis fungoides. lichen sclerosis, very, very epidermotropic, really can look a lot like mycosis fungoides, but it's down there. This is an excision, circumcision sample I had for phimosis, really looks like mycosis fungoides, so this is another lichen sclerosis type of mimicker. It mimics so much that somebody was able to even put it in the literature. I have a feeling that this was a little pitfall, but they had phimosis with mycosis fungoides, which is the same thing I showed you. We already heard about some CD30 positive pitfalls here, looking like mycosis fungoides, right? More CD4 than CD8, very epidermotropic. Involvement of the vessels, more wedge-shaped, and CD30 positive. So this is one of the pitfalls. You guys know what like an LYP looks like, and you also are aware of the different subtypes. And in particular, the type B, small little guys, sometimes are CD30 negative, but those can really simulate MF, so you got to look for the papules. There's also the type E, the angioinvasive, angiodestructive variant that can look like NK T cell lymphoma, nasal type. But these, in this case in particular, the lesions resolved, they were all clustered together, little papules, so that was LYP type C. There's also a very epidermotropic type that can look like lymphoma, and there's the type C, which you already heard, that can look like anaplastic large cell lymphoma. So be aware that lymphomatoid papulosis can simulate an aggressive lymphoma. I might skip this. Let me think what I want to do. We will go through this case real quickly. I'm going to stop at 110. So this is basically a guy who had a patch with little bumps on it. I saw him years ago. He had spongiotic change. Basically, he had spongiotic mycosis fungoides. Here's a little, the little clues, CD4 positive, CD8 negative, CD7 negative. He also had scattered CD30 cells. And then, so he also had little bumps. So then I biopsied the bump, and the bump was involving a hair follicle here in the corner. And you can see that the hair follicle is positive. So I thought he had folliculotropic spongiotic mycosis fungoides. But he had CD30 expression, and so we learned about large cell transformation. A lot of times it's CD30 positive. And so it could be, sometimes mycosis fungoides can just have CD30 positive cells. Sometimes it can be large cell transformation. You could consider lymphomatoid papulosis in a patient with MF. So those are different things you could think about. This is the guy that first described large cell transformation. He died young in his 40s, unfortunately. So, that's going to be in the differential here, all these CD30 cells. And so the thing is, what I did was looked at the patient again, and he had these papules that were CD30 positive, and I just kept following him, and each of these papules would eventually go away. And so I decided that he probably had lymphomatoid papulosis arising in a patch of mycosis fungoides. And so it took a lot of work, but sometimes you have to have follow-up and good correlation with the clin path and the pathologist. So then I stopped seeing patients, and then I got a biopsy. Somebody wanted me to look at something that they got when I was out of town. Spongiotic. I thought, looks like spongiosis, but there's atypia, so wondered about spongiotic mycosis fungoides. Markedly CD4 positive, again, some CD30 positive cells. So when they gave it to me, they said, this is easy, it's transformed mycosis fungoides. Looking at the picture, little papules, it was the same guy. So somebody else now was seeing my patient. The biopsy eventually made it to me, and I was able to show that, and I called him, and he basically said that his lesions just keep coming and going, and he treats it with with triamcinolone, and that it all still within that patch of MF. So he basically had regional lymphomatoid papulosis. And Julia, who's not here, had years ago, when I think she was 3 years old or something, published patients with this regional lymphomatoid papulosis. And one of them had MF in the same spot, just like I did. And then Dr. Heald and colleagues presented cases of limited plaque mycosis fungoides and LYP. So it's rare, but it's been reported a few times. And here are all his localized LYP cases. And they just treated them as if they were MF, and then that helped the LYP go away, which usually, won't clear up. So that just had a lot of teaching points to me, just, persisting on ClinPath correlation and course when you're dealing with CD30 positive tumors. Just acneiform is another thing that can cause a problem with lymphomatoid papulosis. It can look like folliculitis. These are just examples of that in the literature. With the anaplastic large cell lymphoma, there's a rare neutrophilic variant that can look like an abscess or infection. Be aware of that. And then just ending real quickly on a few others. This is an example of ruptured molluscum, which has a lot of CD30 positive cells, so you have to be careful with that. Scabies is another one that can have CD30 positive cells that can trip you up. Chronic ulceration of the tongue can have atypia and CD30 positive cells, but it clears up. That's another potential mishap. And then sometimes you can have CD30 positive cells within vessels as a reactive phenomenon. And so this is just a case of ruptured folliculitis that had CD30 positive cells on the inside, and that's been described by Dr. Kempf. And lastly, about CD30 positivity, another thing that you can see that can look like a different type of cancer is the pseudocarcinomatous hyperplasia that can be seen in patients who have both anaplastic large cell lymphoma and lymphomatoid papulosis. And so here's one in the literature where you have a lot of hyperplasia of the epidermis down here, and then CD30 positivity. This is one that we published. It looked like a big poorly differentiated squamous cell carcinoma. You can see the keratin markers here with a lot of CD30 positivity. And then sometimes CD30 can be expressed in cases that are not T-cell lymphomas. There's a B-cell anaplastic large cell lymphoma. You can see it in gamma delta lymphoma. This is one in which there was angiosarcoma that presents with CD30 positivity. Here's another area of angiosarcoma that was expressing CD30 positivity. So that can be a problem. And then this is a guy who had a gamma delta lymphoma with CD30 positive expression. So I think I'm going to stop there, even though, because we started late.
Yeah,
because I think people want to eat lunch. What?
We can conclude very shortly. If you can conclude shortly.
Okay. Well, I was just going to stop.
Okay.
Well, I can go to my hang on. How do I do this? Oh, well, I just messed up. So, okay, pitfalls. Let's just go to lunch. I don't know. The summary is mycosis fungoides can be missed because of us, the pathologists, because it's not presenting appropriately in the way we expect as a clinician, because the tests are difficult to interpret, because there are tests that don't follow the rules, patients that don't follow the rules, and so, and we will miss mycosis fungoides. We'll just miss it because sometimes it's going to fool us. But just keep following the patient. If they have unusual lesions, they're not acting like eczema, something's going on, just rebiopsy, PCR. You might have to move to the next generation sequencing if that's available here. I don't use it personally for this, but it has a lot of good appropriate uses. And I think that's it. So thank you. Evkaristo.
We'd like to thank you very much, Jackie, for this excellent lecture. It was really a lecture on so many difficult points that we encounter and difficult cases that we see in clinic, and we have to put the puzzle together many times to make the correct diagnosis. So we go to outside for coffee break, and then everybody that wants to ask Professor Hopkins is available.
All right, thank you very much.